So I'm Mike Linke. I'm chair of the University of Cincinnati IRB. I've been doing the IRB chair role, it's hard to believe, but for about almost 20 years. And I've been doing IRB work for probably close to 30. I started my IRB work. I got my PhD through the Department of Pathology at UC College of Medicine, focusing on fungal pathogen Pneumocystis carinii back then. And I did a postdoc at Cincinnati Children's in pulmonary biology. And I finished that up, and then I went down to the VA to work in a lab down there, furthering my interest in Pneumocystis pneumonia. And when I got down there, you know, they're always looking for other things for people to do, and they needed a representative to the UC IRB. And so they sent me. I had no idea what the IRB was. This was 30 years ago. Back then, the IRB wasn't that as involved as it is now either. My main enticement for doing it is they told me I'd get lunch once a month, so that was nice. So I did that, and then during my first few years there, some things happened nationally related to unethical human subjects research, inefficient IRB review, inappropriate IRB review, and all of a sudden IRB started getting a lot more attention and a lot more resources, and really became more of a professional organization and really fulfilling the role that we were initially set out to do. So, it was interesting because I liked it. I loved the basic research, and I continued to do that. I retired from the VA 3 years ago after 35 years of being down there. But this gave me another, outlet and a little more real world application, I thought, than curing Pneumocystis in rats and mice. So, you just never know. I like to tell our younger faculty members to be open to new possibilities, and you never know where it may ended up. So then after I retired from the VA, and I had been chair down at the VA when I was a VA employee, because the UCIRB is also the IRB of record for the VA. The VA doesn't have their own IRB, so they use the UCIRB. And so when I retired from the VA, they hired me full-time to be the chair of the UCIRB and fulfill other duties in the Human Research Protection Program. So that's a little bit about me. Have you guys had gone through IRB reviews? Yeah, good. So you have IRB protocols. Children's IRB probably, or you see Children's IRB? Yeah. Okay, and I see Luke has joined us. Good, so you're familiar with IRBs. I do have this presentation, but feel free to jump in anytime, ask questions, raise issues. Since you go through Cincinnati Children's IRB, you can't ask me when your study is going to get approved. I mean, I usually get that question from people. Why is it taking so long? And that's gotten a lot better over the years too. So anybody have anything they want to bring up before we start? Okay, I'll start this presentation, but as I said, feel free to jump in anytime and change the subject to something more interesting. So talk about the IRB, and the other thing I like to talk about these days are human research protection programs, because they've really evolved recently due to some changes in the how research is reviewed, and mainly related, as we'll talk about, some of the regulations. If you're familiar with the common rule, the HHS common rule was revised recently and has really increased the need for review beyond IRBs, and that's the void that these human research protection programs are filling. One thing I could mention, because Meg and I were talking about it, so you may have heard us, I'm also chair of the StrokeNet Central IRB, and that's a new movement in the IRB world towards this single IRB review that some of you may have heard about. There was an NIH mandate, and then the HHS common rule was revised to mandate single IRB review for any multi-site federally funded studies. So if you get an NIH grant to do a multi-center clinical trial, it no longer goes through an individual IRB at each research site. It goes through a single IRB. And so the StrokeNet Central IRB was set up to fulfill that requirement for a StrokeNet network that the NIH funded, and the University of Cincinnati was awarded the grant to be the National Clinical Coordinating Center for StrokeNet. So all of the StrokeNet, all the stroke research that comes out of NINDS gets done through StrokeNet. And so as part of getting the grant for being the National Coordinating Center, UC also had to provide a central IRB for that network. So that's how we ended up doing that. And that happened almost 7 years ago now. And we're overseeing about 10 national studies with over 500 sites through the UC IRB. So that was an interesting endeavor to take on, and it's going pretty well. And not to go too far, not to get too far into this, but I think you also need to know, if you don't already, there are these commercial IRBs, independent IRBs out there now that also serve this purpose of acting as a single IRB. Commercial IRBs have been around for a long time, but this movement to single IRB review has really increased their role in the human subjects research field. And you know, it sounds a little iffy that they're going to charge someone to do an IRB review. But for the most part, these are really good companies that do a great job. If they're not doing a thorough review and following the regulations, they're going to, not have a business anymore. So that's an interesting development, this idea of commercial IRBs, or independent IRBs as they would rather be called. Cincinnati Children's has not really been in that field. And the children's hospitals in general have been reluctant to move down that path, but they're starting to do it more. And they do the single IRB. Cincinnati Children's was one of the first single IRB reviews also for multi-centered studies. So it has really changed how it works, how the IRB review, at least for multi-site studies, work. And it was done to decrease the administrative burden to investigators and also the institutions and IRBs, and also improve the review process for these studies and hopefully make them safer and more consistent from site to site. So it's definitely still an ongoing experiment, but it's changed a lot in the IRB world. So the UC IRB and then the UC Human Research Protection Program. So here's the learning objectives that Krista had me write up. So I did those. So the real basic purpose of IRBs is to protect the rights and welfare of participants in these trials. That's our basic role in the whole human subjects research enterprise. And then as part of that, we need to make sure that they comply with the regulations. So we do these regulatory reviews. We need to make sure they're ethical, which is a little bit more of a subjective review. And then every institution that conducts human subjects research has their own institutional policies and procedures. So we need to make sure that the protocols are following those. The institutional policies and procedures are based on the regulations. So it's really all part of the regulatory review. And then, just making, I think the IRB review also helps to build the public's trust in the human subjects research enterprise, which we all know on this call is really important these days when there's so many questions about medical care and research in the United States. So, having this, and it's an independent review, that's always important to remember. If an IRB disapproves something at an institution, that activity cannot be done at that institution. So we are really the final determinant on these studies. Now, we can approve things that may not get done at an institution based on other things like budgets. But if we disapprove something, it cannot be approved at that institution. That's the basic purpose of IRBs.
So I'm not sure your slides are advancing, or at least
sorry, I'm on my wrong screen. There we go. Thanks.
Okay.
Thanks, Meg.
Okay. Yeah, great. So questions come up. I don't know if any of you have ever been to an IRB meeting. I think Dr. Joes, is Dr. Joes in this group, Arun? Dr. Joes, I was hoping he'd be here, but he's blowing me off. He's a UC IRB member.
Oh,
He
really?
has been. He has been for a couple of years, and he does a great job.
Yeah.
He really has helped us, and he helped us a lot during COVID. You know, we went through a flurry of activity like lots of people did, especially at the beginning of the pandemic, and he really did a great job reviewing those. So he's been a board member, and you know, serving as a board member, I think, is a good thing to do for young faculty members. It gives you a real good idea of how it works, what you need to do. You also get exposure to a lot of things that are going on at an institution, types of studies, who's involved in what, building collaborations. So, you know, I'm always looking for IRB members. So we, you know, there are regulatory requirements for who needs to be on an IRB. And then there are additional institutional requirements usually. The basic regulatory requirements is there needs to be a scientist and a non-scientist at a meeting. The minimum number of board members per the regulations are 5. A scientist, a non-scientist, you need to have someone familiar with the research to be able to do a review. That doesn't necessarily mean you have to have an expert in that area, but someone at least familiar enough with the research and how it's being done, and really familiar with the human subjects regulations that we need to apply to these studies. In addition to a scientist and a non-scientist, if you're reviewing medical studies, you also need to have a physician on the board in attendance at the board meeting. Most institutions, UC included and Children's included, require that there be a non-affiliated board member or a community member, as we call them, to represent the community, sometimes to provide more of a lay person review of the studies, although we do have community members that are scientists also, so that is, they don't always fill both roles, but most institutions do have this requirement for a community representative. And then the scientists, we have a whole range of different types of professionals on the board: nurses, physicians, PharmDs. PharmDs are great board members. They really know their stuff, the ones that we work with anyway. And then there's social scientists. There used to be, most institutions had a separate social behavioral IRB. You know, everyone thinks of IRBs and they think of clinical trials. Well, there's a whole lot of other human subjects research being done that also needs IRB review. And a lot of it is social behavioral research, survey-based, classroom-based, interviews, focus groups, a lot of that kind of stuff. And so in the past, institutions had separate IRBs for social behavioral research. And as we'll talk about later, most social behavioral research is expedited, so it never actually needs to go to a board meeting. So having that board really did serve a good purpose. You know, we'd have meetings once a month, basically just to have meetings usually, because there was no protocols to review. So we rolled the social behavioral board into the medical board. And now we have social scientists that sit, and it's no longer a medical board, obviously. We don't want to offend our social scientist colleagues. So it's the UC IRB, and we review medical and social studies and social behavioral studies. And we have social scientists then on the board. And really that's helped because you know, a lot of our medical studies now have social behavioral aspects to them, you know, quality of life surveys, those types of things. So having the social scientists involved in the review has really helped. And so the Human Research Protection Program. Most institutions, Children's has one, Human Research Protection Program, HRPPs. They're called different things at different institutions. They used to be known as the IRB office, but with this movement to single IRB review, so even though the UC IRB is not reviewing a study that's being done at UC, another IRB is, there's all kinds of other things that still need to be done at UC besides that IRB review. You know, there's obvious things like radiation safety, protocols that require institutional biosafety committee review. Those still need to be done here. The HRPP / IRB has really, you know, developed into this gatekeeper. So lots of things have to happen before an IRB releases approval of a study. And when single IRBs really became more prevalent, a lot of that became hard to do because the IRB review was being done outside of an institution. So these HRPP programs have become much more involved in the review process. They used to just kind of administer for the IRB and shuffle paper and distribute paper, but now they really, there's a professional certification for human research protection program staff. So the certified IRB professional, there's a big test and a certification for them. So it's really become more of a professional role, and they handle all of those things that have to go on outside of the IRB. The IRB makes the regulatory determinations for approval or disapproval, but the human research protection program really do all that work. So, there are issues with contracts and grants. Most of them have a quality assurance process that goes out and audits studies, and that auditing has become more important now too, as the IRB review has gone outside. The one way for institutions to keep an eye on what's going on is to go audit internal research sites. So a lot of that now has been taken over by these HRPPs. So, it's important to realize people think of IRBs and they think of, reviewing new protocols coming in, but we do a lot more than that. That's the main thing we do. That's the first thing that comes in is we review the new protocols to make sure they meet the criteria for approval. But then once a protocol is approved, there's still other things that get reviewed for that protocol. So there's a lot of modifications. When I first started in the IRB world, coming from the basic science world, I was just amazed. You approve a human subjects research protocol, a large clinical trial, and then a year into it, there's a significant modification to that protocol. It's changed. I don't know, Meg, if, we don't do that in animal studies. You don't change your protocol halfway through it. But human subjects research is different. Things come up. And it's a requirement. If you come up with new information, it needs to be addressed to make sure the participants in the study are safe. So if any of you have been involved in, pharma-sponsored multi-site clinical trials, about these modifications, and some of them can be really extensive. Some of them are pretty straightforward. So you have lots of modifications. They can be expedited. They can be reviewed by a single IRB reviewer if they don't change the risk-benefit ratio of a study, or they may need full board review. And then we have to go back and basically review the whole protocol again. As part of a modification, you need to determine whether or not participants that have already been enrolled need to be informed of the changes. So this reconsent process that investigators hate. But if something's changed in the study that would really potentially impact the safety of participants in the study and change their decision to participate, they need to be notified of those changes, obviously. So there's these reconsent requirements related to modifications. So we spend a lot of time looking at modifications. And then continuing review has changed. This is also related to the revised common rule that happened in 2018. Any study that involves more than minimal risk requires annual continuing review. So every year they need to be looked at. They may or may not need to go to a board meeting depending on what's happened with the study during that year. But that's a lot of work, obviously. Also, you can imagine there's information that needs to be collected, needs to be submitted, it needs to go through the HRPP, then it goes to the IRB. So, that takes some time. Now, the change in the common rule eliminated annual continuing review for studies that involve no more than minimal risk. And we'll talk about those expedited studies. So expedited studies basically don't require annual continuing review anymore. And that was a huge change. And that was really, that really reduced the administrative burden for investigators, but also for IRBs, because we've got to process all these things. So that helped a lot, eliminating that annual continuing review. It was determined for expedited studies that involved no more than minimal risk, that it didn't add any protections to the participants. If something changes on those expedited studies that move it out of an expedited review category, then those need to be submitted, and the IRB needs to review those and possibly change the category of review. And that's one of the things I talked about, the increase in auditing. Sometimes investigators don't understand what may move it out of one category. So, doing these audits every once in a while to make sure that things haven't changed is happening more frequently now. So the continuing reviews, there's these you see, and I think Children's uses the same terminology now because it's related to the vendors packaged electronic IRB systems that everyone's using now. Reportable new information. So these are things that happen on a study, serious adverse events, unanticipated problems, protocol deviations, all those types of things need to be reported. There's criteria for reporting, and that's changed a lot over the years. When I first started, investigators sent everything in. So if you had a clinical trial and you were testing a new statin and someone in the study fell down the stairs and broke their leg, they would send that in. Had nothing to do with the study, but we had stacks of those things, and we couldn't look at them, and it was everywhere. Every IRB had these same problems. So now really the only things that need to be reported are these unanticipated problems involving risk to subjects or others. And so they have to be related, they have to be unanticipated, and they really need to be these serious adverse events. Now, some clinical protocols require reporting of other types of events. Sometimes they want all the SAEs reported, whether they're related or not. And so if the protocol prescribes it, then we follow that. But there's still a significant number of events that come in on a protocol that need to be reviewed, even with the new guidance. And then we also do these non-human research determinations. So there's a lot of activities that involve human subjects that don't actually need IRB review. And we're going to talk about those. I think that's important to understand, or at least be aware of. Any questions?
Dr. Kim, do you have a question?
Yes. So thank you. I hope I'm not interrupting your presentation.
No, go ahead. Great.
So you mentioned about the modifications. There are a lot of sometimes like people request for make a lot of revision on the modification. So like to ask about what I should do when it comes to my project. So I have a usability testing as first phase, and the second phase is the pilot trial. So the usability testing is a minimal risk and it doesn't require full review. So I did submit that as expedited review first, and then maybe I was thinking about maybe modifying or submit as a new protocol for the next phase. What would you recommend I should do? It's usability, it's the same study, but then the procedures are different.
Right. That's a really common question that we get a lot in terms of what turns something into a new study as a modification. So would you be using participants that were previously enrolled in the initial phase of the study, or would you be enrolling new people?
It will be new people.
Okay. Without having all the details, and I'd be happy to look at it more if you need more directed guidance. But since you're enrolling new people, it's moving it out of the expedited category into a full board review. I would go for a new protocol.
You mean the new protocol? Yeah. I see.
So without having all the details. Now, we do get protocols. We do get lots of protocols that we review that combine different phases of studies. There's a real movement now to combine phase 1 and phase 2 studies. So they do the phase 1 study where they do an initial safety analysis, and then they want to move directly into the phase 2 with that data, and they don't want to go through the whole review process again. And the other thing for those, they also don't want to go through the whole FDA review process again. So they do that, they kind of combine it all. So we are seeing more combined studies like that. So, I think, it's kind of a nuanced decision on which way to go, and I might need more information to give you really clear direction. But my initial idea that since you're enrolling new participants and it's going to move it out of the expedited review, would probably be better to do a new submission.
Got it. Can I ask one more question?
Sure. Yeah.
So I do a lot of social science and community-based research projects, and I use storytelling as a way to educate people and also use that as an intervention. In my previous institution, they did not require, they didn't see this as a research project, as this is like a part of intervention, and we do not like collect data or analyze. So we didn't have to go through the IRB process, but it really depends on like how institution sees the storytelling as a research project or not. So I would like to hear your thoughts on it. Like, when it comes to do like a storytelling work, I'm always think about whether I should go through the IRB review just in case, or can I just go ahead and do this intervention work, develop.
Yeah, I mean, the one thing you can do is, and Children's has the same process, you can submit an initial request for a non-human research determination and give them the information about the activities you want to do. And then I think we could move, if we look at this, yeah, let's talk about this because we can use your study kind of as an example. So IRB review, in order to need IRB review and be considered human subjects research that requires IRB review, first it has to be research and it has to meet this definition of research. So that's the first thing we looked at. So if you submitted your activity and you wanted to know whether or not you needed IRB review, we would look at it and determine whether or not it was a systematic investigation. Kind of sounds to me like it is. You've got a hypothesis probably and a protocol. And then, is it designed to develop or contribute to generalizable knowledge? And I would say it probably is. I mean, you want to publish this, you want to change the field's thinking on whatever it is you're researching. Now, there has been, as part of the changes to the common rule, a specific designation that research involving oral histories. So if you just go talk to someone about their own impressions on something, then that has been specifically determined in the common rule not to be human subjects research. But it doesn't sound to me like your activity's doing that. Who's doing the storytelling? Are they doing the storytelling, or are you presenting them with stories?
So I'm interviewing people to capture their stories.
Okay, well then that might actually fit into this new determination that was in the revised common rule, that oral histories have been determined not to be human subjects research. They still meet this, and it's more related to the next determination we make that whether it involves a human subject and whether or not you're actually obtaining information from them about them. It's kind of difficult to tease out, but if it is research, then we would look into whether or not it was a human subject. Let me go back though, because I think I misspoke. So I think that the revised common rule has specifically determined that studies involving oral history are not research. That's why it doesn't fit into the IRB review category.
I see, but I have a question about the term generalizable knowledge.
Yeah.
Is that refers to like publication, or does that also has to do with like conference like presentation as well?
It has to do with both, and this is a little hard time to wrap my head around too. But this is the current guidance is that, and it's more related to quality improvement work. So quality improvement work is not determined to be research that meets this definition because it's only being done to improve the activity at the institution where it's being done. So if the University of Cincinnati Medical Center is implementing some type of quality improvement study to improve an activity being done at UCMC, then it isn't designed to contribute to generalizable knowledge. It's quality improvement work. And then the current guidance says, even if you publish that, it doesn't make it generalizable.
So I had a question
I
about
think that's
that.
hard to understand because once you publish it, who knows what happens to it, but that's the current guidance. Go ahead, sorry, Luke.
Well, I had a question exactly about that because we commonly run into this, especially with smaller projects from fellows now. It's sort of like, well, I guess that could be QI, but the reality is that anybody that's working on it would like an academic product. And so there is an intent to publish, I think, if there's a successful intervention, and the people can say, oh, look at that, it worked at Cincinnati, maybe I could do it too. So what do you guys do with that? Because a lot of the work that is done clinically that's smaller is around quality improvement and could technically fall in that category. But I've received like feedback in the past from mentors and others to say, if you intend to publish it, it's just safer to get it approved, go ahead and submit it. And so would you have anything other than that to say, or?
That was always the current approach. I mean, the previous approach. But in the last probably 5 years ago, it's become well accepted that publishing QI data does not make it generalizable and make it research that fits this definition. So it really comes down to the purpose of the project. What is the purpose of the project? And that's another thing that's changed over the years. IRBs used to, and some still do, but we don't do it here, used to argue with investigators because they'd come in and say it's QI, it's only being done for QI, and we'd argue with them. But it comes down to the investigators. If they think if they're doing it for QI, who are we to say they're not? But if they really aren't, then you go down a path where you do start to get into some problems. So the other thing now, a lot of this work would probably be no more than expedited review anyway. And so with the changes of the common rule that don't require continuing review anymore, the recommendation to just go ahead and do it may not be that bad. And it's not a bad thing for young faculty members to go through either. There used to be people used to work so hard to avoid IRB review, and it would have been just easier to go through the IRB rather than, trying to avoid it. If it is really not research that meets this definition, there's no reason to go through the IRB. There are certain things you need to do when you have human subjects research approved by an IRB. So there's definite responsibilities. The other thing we did is, go ahead.
Well, I was going to ask if you have an example, because this gets, in the research world, QI is it's not a very fundable long-term career building thing for your CV, right? So, but implementation science is becoming so. And so I think that there is some ambiguity between where does that QI stop and the implementation science begin? And so I was wondering if you have any examples, or this could be less abstract, or you had one where you debated with somebody, or you felt like, I think this is really research, but they were like, no, it's just QI. Does anything come to mind, or?
Not off the top of my head right now, but what does happen, and we've had this happen, is where we determine something non-human subject research because it's QI. And while they're doing it, it's like you mentioned before, all of a sudden they see something that's really interesting and they want to turn it into research. And that can be done. You want to recognize that and then resubmit it, and then we could re-review it as research. So, that is something that I tell people that, if you do think that this is going to cross the line into research, then bring it back and we can review it as research. The one area and it's not probably a great example, but what happens sometimes, and I see this with faculty that are doing research related to like physicians, and they don't always understand that the physicians are actually subjects in the study. You know, well, we're not enrolling any patients. You know, we're just doing this on the physicians. And so, you know, sometimes that moves it over into research too.
So
Thanks.
my case was I did like a social justice related work, like on like racism and discrimination and using storytelling. And so this was a non-human research subject project, but then I was invited to like a conference to talk about this program, and I was advised that I need to go through the IRB just because it's considered as generalizable knowledge.
So, you know, that's the nice thing about that non-human research determination process, because then you'd get a letter that you could show them that the IRB determined that it was not human research.
Okay.
But it, you know, like Luke said, you know, sometimes people just say, go ahead and do it, whether you need it or not. But, you know, that isn't necessarily the best approach either.
Yeah. But I agree too, like it is not as hard as it used to be. And it's for fellows and other people, it's a good experience to like try to sort through the paperwork and understand what these questions are they're asking and is it relevant. So. And
then the other issue that comes up is sometimes things that are not human subjects research can still be risky. And who's going to review those, you know, if we don't? So we do sometimes get into that. There's other issues like HIPAA, you know, if people are accessing electronic health records and it's a non-human research project, you know, we are all UC IRB, I think Children's is too, the privacy board. So, you know, who's going to take care of the HIPAA determinations? So it definitely gets complicated when you start going down that path. And there's been talk about having a separate type of review for those types of activities. And a lot of them happen at, you know, your like Cincinnati, we see they happen over at the medical center, you know, which is actually a separate entity. And so they become more concerned about those types of things. And since we have such a close relationship, we do have a method to notify them when those things happen, so at least they're aware of them going on. You know, medical centers and hospitals don't like it when they find out secondhand that something's going on there that they don't know about. So that, you know, you need to make sure it's research. And I think, Kim, in your case, based on the revised common rule, what you're doing probably doesn't meet this definition.
Krista,
have you gone through the Cincinnati Children's IRB yet? Have you talked to anybody there?
I went through the UC IRB.
Oh, you're at UC.
Mm-hmm.
And what did we tell you?
Well, I just submitted for review before I did.
Oh, you just submitted it?
Conference presentation, just to make sure I didn't want to get into like any complications.
Okay. Well, then I should see it. You haven't got a response yet.
I did. But I have a more. So they approved that this is like a non-human
subject
related project. So I got the letter. So now I can just comfortably like present that work at the conference and other places. So just wanted to check with you because if I need to always like go through this process every time I do non-human subject related project using storytelling. That's all. Yeah.
Good. It's good to do it because then you have the documentation, you know, and per UC policy, whenever anyone's doing anything that might be considered human subjects research, you're supposed to submit it to the IRB to make that determination. That's not actually required by the regulations. And realistically, if you're doing something and it's not human subjects research and you didn't get an official determination, but it's clearly not human subjects research, you're fine. The problem comes in is when someone doesn't do it and doesn't recognize what they're doing was actually human subjects research. And since it can be a kind of a tough decision to make, that's why we always encourage investigators to let the IRB help them with that decision. But if you're using the same basic techniques every time over and over again, then you probably don't need to submit every one,
Oh, okay, that's good to know.
you know. But be careful.
Of course.
Krista, I know you have a question in the chat. Did you get your question answered?
So it was more to you about Dr. Kim's research. So I will have to submit, since she's a case scholar, prior approval for her, and we need IRB determination of what the risk level of her project is. And I guess I'm wondering, either Dr. Kim or Dr. Link, on your conversation about the protocol for her, if she's going to need 2 separate IRBs for the storytelling and then her pilot trial, or is it just one IRB approval and 2 separate protocols? I don't understand the process very well, and I'm not from a scientific background, so that part's a little confusing to me.
So your first phase was this non-human subjects research, Dr. Kim?
Oh, no, it was actually, the storytelling project is another one. This
okay.
KO2 research project is the first phase.
This other one was approved.
It is required.
The other one was approved as an expedited study.
Yes, that has been approved as expedited.
Yeah, so it would be 2, if you go down the route of doing another submission, it would be 2 protocols.
And I guess Krista has a question that since she has to report, and I have like 2 IRB applications for my project, I wonder how, I don't know. Krista, is that
why don't you email me after this, okay? With your protocol number for the expedited one and what you want to do, and I can give you better direction that way than just doing it over here.
Thanks.
Okay. So research, and then it needs to be a human subject or a living, and it's a living individual, which is always interesting because people come to us with doing research with autopsies or post-mortem specimens, and that doesn't meet the definition of a human subject. So, and you have to collect information about that person. A good example of that is, if you're just asking people on the street what the price of gas is at their neighborhood gas station, you're not collecting information about them. But if you ask them what they think about that gas price, then it is about them. So that would move it over. The change in the common rule added the biospecimens to this definition. Before it was just obtains information through intervention or interaction with individuals, but now it's identifiable biospecimens also. So that was the change from the common rule. So it's this category here. It has to be researched by the definition, and it has to meet the definition of human subjects to be considered human subjects research that needs IRB. And then we've been talking about these, but there are definitely different levels of IRB review. There's this initial that we just spent a lot of time on talking about not human subjects research. Doesn't meet the definition of researcher and or human subjects. And then the next level is this exempt category. So the exempt category is human subjects research. However, it fits in one of the categories that is designated in the common rule to not require, not to have to meet the criteria of the common rule. These studies have been determined to be of such low risk that they're exempt from following the regulations. So they still get reviewed by the IRB. The IRB at UC makes that exemption determinations. However, that was another change in the common rule that allows institutions to implement other ways to make this exempt determination. So departments could set up a process to make their own exempt determinations. And when that first came out, a lot of our investigators and departments here were excited about that. And they thought they weren't going to have to go through the IRB. And then they started thinking about it, and they started coming up with plans to somehow do this, and realized that it was, again, going to be more work to set up a whole separate process to make these exempt determinations on their own. So nobody here has done that yet, and all of these exempt determinations come through the IRB. And then the next level is the expedited review, which are studies that are no more than minimal risk, and they fit into one of the expedited review categories in the common rule. So things like low volume blood draws fit the expedited category, using identifiable information, doing chart reviews, all those kind of things. Social behavioral studies, surveys, focus groups, most of those will fit into the expedited review category. Sometimes if they're looking at sensitive information, it may move it out of the expedited review and into the full board review category. So these are the studies that are more than minimal risk, your clinical trials, device studies, all those types of things. So these studies get reviewed then at a meeting, at a full board meeting. The expedited reviews are done by a designated board member. Exempt reviews a lot of times now are done by HRPP staff, staff that are trained to do those exempt reviews. And some of the non-human subjects reviews are done by HRPP staff too, in collaboration with IRB members. I think one thing to remember is expedited review does not mean fast. And then sometimes expedited review can take longer than full board review because expedited reviews are done by a designated single board member who is a volunteer and has lots of other responsibilities. And we give them 2 weeks to do these reviews, and sometimes it takes longer, but expedited doesn't necessarily mean they're faster. But we have gotten better at turnaround times. I think we're almost out of time, and I don't know that we really need to go through all of these. I can mention them quickly. I hope all of you have heard about the Belmont Report. The Belmont Report was developed mainly after the experiments on syphilis in the Negro male and Tuskegee were uncovered, and it was set up by the National Research Act in 1974, and they were charged with identifying these basic ethical principles. And so now we have the ethical principle of respect, and respect is really reflected in these things that the IRB looks at in terms of voluntary consent. There must be the consent must be able to be understood. You have to protect privacy and confidentiality, and that the participants can always withdraw from these studies. So those are the things that we look at related to the principle of respect. And then there's this beneficence, that you're really doing good and there's an obligation to do good. And that the studies are designed with a good risk-benefit ratio. And the IRBs evaluate those risk-benefit ratios. Sometimes studies don't have direct benefit to participants, but overall there's a good benefit to society that we can consider during review. But those can be hard, and then it's hard to get participants to understand that. And then the last one is justice. And justice is really focused on the fair selection of participants for these studies. And this kind of went back to the unethical research that was done in the Nazi concentration camps during World War II. There was no ethical selection of participants for those subjects. There was no scientific basis for selecting those people. So you can't just select certain groups of people because they're easily accessible. Prisoners also fall into this category. There's lots of rules for doing research with prisoners. And then in the US, we have the FDA regulations. We haven't talked much about them and those, but then the other are the HHS regulations. The FDA regulations on human subjects research pertain to any research being done with drugs, biologicals, or devices. So these clinical trials, anything that's going through the FDA approval process. And there's two different sets of regulations. But one talks about the requirements for informed consent and what needs to be in it and how it needs to be documented. And then the other part talks about IRB functions and the criteria for approval. And so these FDA regulations apply to all clinical investigators. And then the other is, we have been talking about this. So this is the common rule, 45 CFR 46, and this applies to any federally funded human subjects research. The requirements are, the criteria are very similar to the FDA regulations. They're all in this 145 CFR 46, so they're not split into two. But again, you're talking about IRB functions, criteria for approval, the informed consent process and documentation. So they're similar. There are some differences, and there are some cases where some research has to follow both the common rule and the FDA regulations. You know, for example, if you get a NIH-funded grant to do a clinical trial, that has to follow both sets of regulations. There are nuanced differences, but really there aren't any major differences between these. However, the FDA does not follow the common rule, and they have not adopted those changes to the common rule, you know, things like eliminating continuing review and those types of things. And the single IRB review mandate doesn't actually apply to FDA regulated studies. It does apply to federally funded studies. And then the common rule has the subparts for these vulnerable populations. So special protections in place to protect these vulnerable populations. So specific things that need to be in protocols and consent forms when you're working with these groups of patients. And then these are the UC SOPs that are based on the regulations, and they're available on our website. And those are really what we start with when we're looking at these studies. These are the basic criteria for approval of a protocol, something we talk about at board meetings. And I think one of them that we point out is that it does have scientific merit. Some investigators still think that IRBs don't look at scientific merit. They're not supposed to look at scientific merit, but evaluating scientific merit has to be part of a risk-benefit analysis of a study. If something doesn't have good scientific merit, you know, what's the benefit of that study? So that is something we do. We can rely on others for that scientific merit review, and we have a pre-scientific review requirement for studies. For cancer studies at UC, the Cancer Center has a protocol review and monitoring committee, so we rely on them for the scientific review, but it is something we need to look at. And then these are the required elements of an informed consent. And these are mandated by the regulations that these need to be in there. The information in the sections is determined on a case-by-case basis, and there's, you know, a real movement to improve the understanding of consent forms and reduce their length. We just saw one yesterday. It was 33 pages long, and you know, who's going to read that? Who's going to understand that? So, you know, that's something that's a real focus now in terms of improving the understandability of these consent forms. Consent can be waived. There's various situations that where informed consent can be waived or even altered. So that's something just to remember. And there is in the United States regulations that allow research to be done without informed consent, and that's more than minimal risk research. This exception from informed consent for emergency research. We have a number of those being done in Cincinnati, and it's a whole separate set of regulations that need to be followed for this EFIC research, but I think it's important to point that out so people are aware of it. So we made it through. Thanks for the questions and conversation. That really helps. And Dr. Kim, email me, okay? Here's my email. And I can look at your question on your second protocol.
Would you be willing to share your slides too?
Sure.
That I can
Yeah.
send to everyone? Thank you.
Yeah.
Thank you very much.
You're welcome.